to the Phelan-McDermid Syndrome podcast, sharing research, progress, and hope. Today, we have two outstanding guests here to talk about the latest findings from the Natural History Study. First, we have Dr. Audrey Thurm, a clinical psychologist who ran the Natural History Study at the NIH. Dr. Thurm is also on our PMSF Scientific Advisory Committee, as well as our Neuropsychiatric Consult Group. We also have Dr. Latha Soorya, a clinical psychologist and associate professor at the Rush University Medical Center. Thanks so much for being here today.
Thanks for having us.
Thank you.
So you both have been involved in the Natural History Study, which has been funded by the NIH since the first phase in 2015. You have been essential voices in the Phelan-McDermid syndrome community. But for those listeners who maybe do not know you as well, could you tell us a little bit more about how you found your way into Phelan-McDermid syndrome world and your current focus? Audrey, why don't you start?
Great. Well, here at NIH, we ran a lot of research on autism and intellectual disability and multiple rare genetic conditions. And this one, I have to say, in over 15 years ago now, it was actually a father who was quite an advocate who came to our group knowing we were studying rare genetic conditions and brought up Phelan-McDermid syndrome. And this was actually before the multi-site study started. So this was a single site that we started in the intramural of NIH, and then within a year, the network formed and we applied for the grant. So we knew that becoming part of multi-site would be essential because you cannot do this work alone. And I'm so glad that the multi-site study started.
Absolutely. Latha, how about you?
So I came in through my initial faculty position at Mount Sinai. I was chief psychologist there, running a lot of autism studies, and we know the history of Phelan-McDermid syndrome and the work that was being done at Mount Sinai and the basic and the early clinical studies. And so I was tapped to figure out how to work with the population, how to design testing protocols that might be more relevant than the ones that we had. And some of that trial and error is what you're going to see in the work that we're describing today.
Fantastic. So taking a step back, tell us a little bit more about kind of what a natural history study is in general, and then what it's really hoping to accomplish in Phelan-McDermid syndrome.
So I'll start by saying that again, the foundation, and I mentioned the father that helped us, and parent advocates have been driving all of this, and it's amazing. And parent advocates early on started a registry, knowing that we needed to know who has the condition and some at least basic things about the characteristics, including what the genes involved and how big deletions are and things like that. But we know that that the FDA and just science requires that we have just a much broader understanding of a condition, including what happens over time and what happens in multiple ages, which we just didn't have about Phelan-McDermid syndrome. I mean, remember, it hasn't been identified for very long, and certainly the cases that are by sequence variants, not deletions, but sequence variants have been much more recently identified. So we just need to know about the condition. In order to do that, we want to be systematic about it. We can get reports from cases and from patient records, but we want to actually prospectively use the same measures on the same children over time to see what two things. Number one, how individuals perform on those measures, which lets us know what the symptoms are, what the development of different domains are, but also lets us know which measures are going to work and not work. And that's just both of those things are so important to identifying what the best outcomes would be for any treatment trials and for understanding what measures would be helpful and useful in those trials eventually. So that's just like basic goals of a natural history study.
I think it's really important that, you point out both we're trying to understand the disorder and and get a sense of what it looks like over time and across time. But then this other piece is really finding this information out to help inform clinical trials. So can one of you explain kind of what that looks like, or, why that is so important then?
I think that to that point, I think it's both for informing clinical trials and clinical care. We separate them, but I do think that they're both part of sort of the purpose of understanding the breadth and the diversity of symptoms, but also some like sort of common domains. So, I think that most of the measures that we have access to or that we understand the best are not designed for children with intellectual disability. And so we're forced to adapt things that are required by whether it's the FDA or journal reviewers or science at large to a population that it never was meant to be applied to. And so I think that part of the natural history study and the work and getting us ready is to do this trial and error and be able to demonstrate what works and what doesn't work for the particular populations we're working with.
Yeah, exactly. We could go into why these measures don't exist, because measures normed or tested on a wide group of people, and they're tested on a wide group of people that do include some people with delays and impairments and intellectual disability, but they don't include too many. It's difficult to norm a test only in a very small population. So it's part of the issue with tests in general.
I appreciate you going into that. And I think that's a piece that it's hard to share with families. But I guess I'm also thinking back to families and going through the natural history study. It's a big burden for them, being a parent and bringing your kid in for hours and hours of testing to find out a measurement is not great.
Right. And so then one thing we can just say is that doing this podcast is just a drop in the bucket to show our appreciation. And again, it's all reciprocal to give back to these families who gave so much to us. And we understand that we need to explain why it is so important and how grateful and how amazing it is that we had 100 families in the first 5 years and then many more more recently contribute travel, take the time, bring siblings with them, not have school, get off of work, and then answer questions that didn't seem terribly relevant for a lot of cases and a lot of things. But that work, that commitment gave us so much information about the condition. And then again, we have a whole big checklist, and that's the first paper we're going to talk about, of measures that we said, nope, we won't be using this any further. And so that in itself was so tremendously helpful. But then we did find some and some different ways of measuring things that do feel like we can move forward with and tell drug companies and those involved in treatment that this is what we should use. And Latha's right. And hopefully clinicians out there who are learning about the condition, have patients, will pick up on this as well.
Absolutely. And so, great segue. I'd love to dive in, because one of the main reasons I brought you guys here today is that there is going to be a new special issue of the American Journal of Intellectual and Developmental Disabilities featuring multiple papers from the natural history study. And so there's so much rich findings and a lot that can be applied clinically and for our families. So let's dig in.
Get it started if you want.
Yeah.
So there's 5 papers. I think we're not going to go through all of them. But the first paper that we thought we could share is just the initial characterization. So many families prior to even the natural history study participated in these single site studies either at NIH or Mount Sinai. And through those, we started to understand the need that we needed a bigger sample, we needed multi-site studies. In that initial paper, the goal was to understand how we can measure key behavioral and cognitive domains across syndromes, while also providing an evaluation model that gives us a in-depth look at syndrome-specific needs. And so that balance was a outcome of lots of conversations, lots of wrangling and compromise. But fundamentally, the battery that we have or that we developed is what we are describing in the first paper in the special edition. And we're looking just at the baseline. I think we went in with a bunch of goals. So the goals were to understand possibly measures that captured similarities across the conditions, and then broadly identify candidates that could help us understand what might be useful for clinical trials. So clinical trial readiness was another goal. And then the goal ideally was to sort of identify the places, as I said, where we can use both like measures for across syndrome diagnosis and within. And in PMS, there was an understanding that PMS is different than others. So we found higher rates of intellectual disability in Phelan-McDermid syndrome. There were about 3 standard deviations on the IQ level below the P10 group, and then TFC was in the middle. There were measures that just did not work for the vast majority of the group that participated in the initial DSC within the PMS sample. So these findings are what we highlight. So what were across syndromes, what we understood, where the sort of profile was, and then what are the measures that didn't work when we talk about Phelan-McDermid in particular?
Yeah, I really appreciate that overview. And just for the families listening, the DSC acronym is that larger study that has all 3 of those groups. And then kind of within the Phelan-McDermid world, we've just sort of labeled it as the Natural History Study. And so those terms are interchangeable. And so I'm sure throughout this podcast, you'll hear a little bit of DSC as well as the Natural History Study. But for all intents and purposes, they are the same thing. I think it's really important that you did take that step back to really emphasize that this initial study laid really important groundwork for the future, and not just the future natural history studies, but even, other future research studies, not clinical trials, obviously clinical trials also being important, but then also, it's really informing what is being done clinically as well. And you're both clinical psychologists. And so I would love to kind of probe a little bit about that, of like, why is that important? How does this work inform your clinical practice?
That's a really great question. And I do think some of the more impactful papers, and hopefully not just a personal professional opinion that came out of this, were out of the natural history study, were things like clinical recommendations. So some of our, the network did produce several practice guidelines based on some of the work that we had done. We have published at least 2 papers geared towards evaluators, psychologists, trying to understand or share what we learned. Some of the things that we learned were, there is a big push for a lot of reasons to look at autism in Phelan-McDermid syndrome, to look at skills that in many ways are above the developmental expectations for many individuals with Phelan-McDermid syndrome. And so we were able to provide some practice guidelines about like at what age or what developmental level, and really like anchoring age and developmental level as part of our calculation as clinical psychologists and what tests we use. So what age and what developmental level do we assess motor, cognition, attention, social skills, social communication skills, executive function. So when is it appropriate to ask these questions? And then Audrey, I'm gonna pass it off to you about some of the work that you've been doing on sharing some of the findings and how we use some of those findings in practice.
We took the approach, and we've done this not just for Phelan-McDermid syndrome, for many, many, many rare genetic conditions, that we were saying that Phelan-McDermid syndrome is different from the other two, but it's not different or in the sense that there are many other rare genetic conditions that do require this idea of what we call out of age range testing, or testing using a test that would be that it was normed for a different age group. And you can do that if you're not worrying about those quote standard scores. It just means that in certain skills that's the equivalence. But then the other idea is that with this study, we thought it was so important that we don't just care about where a child is at one point. We care about how they're moving over time, how skills are growing or developing or being lost, which we learned through the study was something that we unfortunately had to see and document. So for that, you can use a different kind of score, a different kind of metric that tests have, which are called personability scores or Gross-Gavais. The name isn't important, but it's a score that measures the child only against their self over time. And so we realized that not at the one point in time, not the studies that Latha just mentioned, but other studies, including one that we're going to talk about, we can focus in on how kids measure against each other over time.
So I'm glad that, research scientists are figuring out a way to do that. The other thing I wanted to go back to that you mentioned, both of you, was kind of then thinking about what else did we learn specifically from this baseline paper? You mentioned that there was a higher percentage of intellectual disability in Phelan-McDermid syndrome compared to TSC and P10 hematoma, but what else can families take away from this paper, or do you guys think are important takeaways from this paper?
I think I should clarify that it wasn't just the rate of intellectual disability, but also the severity of intellectual disability was distinctive, I think, in our Phelan-McDermid population. There were, for us, we grappled with this, the data for a while, in that it's not like a tricky analysis. It was really just a challenge in really making sense of the heterogeneity in the responses. And I think one big takeaway for at least me was that we had several gaps that we don't have good measures to fill. And then that is, from my background is in behavioral therapies, and really we have very few candidates to appropriately measure challenging behavior profiles in medically complex, severe to profound intellectual disability populations that will help inform treatment planning or clinical work. So I think that was something that came up. And then the second part was caregiver reports, and we'll talk about the main finding around the Vineland, but that caregiver reports tended to be, was the most reliable and most reflective measure across populations, but particularly in our Phelan-McDermid population. And that data then was sort of the platform for some of the other studies that are in the journal or in this special edition, but also, as we'll talk about, is being used. So the Vineland in particular is what's going to be used in trials going forward until there's something else.
No, I'm really glad you just mentioned that, because I think talking about all the limitations with tests and using different tests and everything, I think what we know as clinicians is that we never want to rely on just one source for anything, certainly for diagnosis, but even for measuring functioning. And so we really did that in this paper and with this research. And that's why we had so many different measures that we asked people to do. And we also know that kids are not going to, quote, always do their best in person with us. And so we do put it together, and we even displayed in the paper the adaptive functioning alongside with the cognitive test to show how they do back each other up mostly, but then there are some cases certainly where parent report is showing a different story, and that's so important for us to see. But in general, things went together in showing us again that there was quite a bit of severe and even profound intellectual disability, but again, there was huge variability, and so that is something that is challenging, but in a good way, right? Because there is that variability, and we know that the condition does span different levels of impairment.
Right. And something before we jump into those adaptive skill papers, is that I also wanted to mention, these measures, as you pointed out, were normed on a typically developing population. But with that, then it's populations that tend to not have motor issues or attention issues or challenging behaviors. And so all of those things can interfere or make testing more challenging. And so even if a kid has a skill or knows an answer, if they're not able to manipulate an object in a certain way or verbally express themselves in a certain way, then you might not see those skills, even though parents are reporting like, oh yeah, he's able to do that. It just requires some augmentation or alternative device. So just wanted to throw that in. So let's dive in. So Sid at Boston Children's and then Tess Levy at Mount Sinai both had some papers looking at the Vineland and adaptive skills. So what kind of things did they find from the Vineland?
So those two papers, as opposed to the one we just talked about, actually include longitudinal data over a few years. And so in those papers, we didn't just rely on those standard scores. We did use those gross scale values to look at trends over time. And we did see that those standard scores, do not show improvement over time, as we would expect, because in order for them to actually show improvement, the children would have to be gaining skills at the level of someone of their chronologic age. And that would be a jump that we wouldn't expect anybody to do. And so we can use those gross scale values to see it with statistics, both within individuals, if they're improving, and taking that into account to look at the whole group. And so we did see that for some areas, like receptive communication, so understanding, and then personal daily living skills, like learning how to, dress and take care of yourself and feed and things like that. We did see some improvement in those gross scale values, which is so incredibly important for us to know that even, this is the natural history. So this is kids with, quote, treatment as usual, not, they may be taking different medicines and different things. It's completely variable what they're doing. But as a group, the kids with Phelan-McDermid syndrome did seem to show growth, again, based on where they were before, over years, in some of these skills. And that's really, really helpful for clinical trials to have exactly that, the natural history. So we can see how that might differ, be better, or, could be worse with kids in trials. And sometimes that data is actually what the FDA looks at. They look at that this natural history data compared, because some of these trials, especially in the beginning, when you're piloting, are just teeny tiny samples, and you can't have a control group necessarily. So this data can be used in that way, and certainly by the drug companies or people that are looking at what they would expect.
Mm-hmm. I'm just going to jump in right there, because I also think it's really important, because probably a lot of the, psychological reports these parents are receiving only have standard scores. And so these scores that kind of are relative to the normed population. And so they're never seeing growth. And if anything, they're likely seeing decline. But that doesn't mean there's a decline in skills or a loss of skills. They are gaining skills just at a rate different to their peers. And so looking at the data that you just found, I hope brings some hope and optimism to parents of,
Yes.
yeah, especially in these areas of receptive language, which is so important to, increase in skills in your understanding of language, and some of these kind of personal hygiene type skills, those are increasing over time. And so that's great news.
Yes, it is great news. It is great news. And I would say though that as much as parents have had to be advocates to get genetic testing, get their kid into clinics, get their kid into school, get their kid healthcare, with this knowledge, we hope that they can also be advocates with their clinicians in schools to be looking past those standard scores, to be trying to figure out ways that they can, use this for their IEPs, for goals, for seeing change. So we really hope clinicians and parents can be taking this information to the next level.
Absolutely.
I think might be a good time to plug your article, Audrey. I don't know if we can link it for families to share with their clinicians on the article that you and Kristen and Natasha have written. Do you want to say something about it?
Yeah. Just that we know that this type of approach is really not being used out there. So we did publish something specifically for clinicians to think about how to change their reports, incorporate it. Again, this is when they see kids over time, which we certainly hope is what's happening, because it is also critical that even if kids are not being followed in studies, that these kids are being followed over time. And I don't know if we want to talk about which paper we want to go to next, but maybe I'll just really briefly mention another paper, because I know those who have what we think of as small deletions or large deletions or variants, they know that there's something different about some of those things. But did we look at that? Yes, we looked at that in a totally separate paper because that's so complicated in itself. So really quickly, that paper called Class 1 as I think up to 4 genes at the very end of 22q13, and then larger as Class 2, and then a separate group for variants, formerly called mutations, where just SHANK3 was involved. Although, as we all know, those can be very different point frame shift, different kinds. So we did group all that together, which again, probably the next paper won't.
Thank you for mentioning that you have sort of this clinician guide. We will definitely plug that in our show notes. And I think that's also, obviously I hope are some clinicians listening to this podcast, but again, another way, a parent can advocate, print it out, give it to their psychologist or school team of, hey, look at this. So with these 2 papers that are looking at adaptive skills over time, is there anything else that was particularly surprising that you found, or kind of anything in addition you haven't mentioned yet?
Well, I think in that last paper, we did actually see a little bit of loss in actual skills in the SHANK3 variant group, and that sort of leads to the other paper. So that may have been accounted for by a few individuals who had a regression, and so in general, what we saw even in the first time we saw kids was that some of the older kids, teenagers, and especially those, there were several that were just getting a diagnosis based on having a change, new psychiatric symptoms in adolescence or older. And that was something that, was unexpected, that we really didn't know about. We had already been asking about regression anyway, both in this study and then amazingly the registry, the foundation, did all the work for. We put those two together and we looked at loss of skills in a separate paper because of these anecdotes we were hearing about and because we're concerned about it all the time anyway. Now, this paper and the skills that we asked about, we partly asked about because we know that a lot of kids with Phelan-McDermid syndrome weren't developing these skills at all. So almost everybody developed walking, but even things like walking up and down the stairs on their own at a regular pace, riding a tricycle, but then even other skills like pointing, being able to have social interaction in certain ways. We were seeing high rates of not developing. So we took that into account, but then we were looking at who developed certain skills, although these are all sort of early development skills, and then who lost them. And we did find, pretty high rates, either up to a third of kids if we were asking more broadly, or even higher rates than that when we were asking about very specific skills, had lost at least one skill. And that, was something that we are now very, concerned about. And one thing we did see again in this paper too was that a lot of kids, more than we expected, were losing skills at older ages, like after age 10. And so this is a very sort of cursory look at this. And it led us to now change and ask even more questions about loss, especially loss that might happen in older kids in our subsequent studies that we've been doing.
Right. And some things, I definitely want to highlight there is that kind of in this loss of skill paper that you're talking about is you did take data both from the natural history study, that was like one part of the analysis, and then you took data from the PMS-IR, which is our the Foundation's initial registry. And so I think it's also this like great way where even though you have two separate data sets, I'm sure there are some patients that are overlapping there, that you're able to sort of come up with similar conclusions, but they also uniquely tell you different things. And then the other point is as we were talking at the very beginning, the natural history study has informed the future natural history study and what you guys are looking at now. For instance, by really identifying that loss of skills is not necessarily just taking place in an early developmental period that we typically think of in like traditional autism cases. There are these other times or kind of loss of skills can happen kind of after age 10, which we're all trying to figure out a little bit more of now.
Yeah, and one thing I want to add is one of the things we asked about, but need to ask a lot more about, is whether kids then regain skills. Exactly. And some kids absolutely do regain skills that reported, but we need to dig in a lot more. And I'll just say, I know this is concerning to see, but we don't want to ignore it. But again, a lot of the things that we're looking at, and this one especially, is just not easy to report on, because you need to ask, did the child have a skill for a certain amount of time, and how long was it lost for, and making sure that it wasn't just lost because someone was sick and then they gain it back. So we need to make sure that we're on the same page, and we're still learning how to ask these questions better.
And I do want to do a quick little plug, because I think this is an area that the foundation has obviously noted as a huge hole in the field, and something that we do want to take more time, consideration, effort, hopefully money towards. So, I hope with you two right here and some other experts in the field, even just like you said, defining what regression or loss of skills means in terms of timeline and, do they regain the skill back? I think that's definitely something that hopefully as a field we can move forward and better help figure out what that is. Thinking about a lot of these papers all together, what does this mean for behavioral intervention? Obviously, we've sort of hinted at some pharmacological clinical trials, but what does this mean for behavior?
Something I've taken away is that the measures and the outcomes are actually quite similar across, whether we are looking at a gene therapy, pharmacological intervention, or behavioral intervention. We all sort of want the same outcomes, right? And on the way that promising measurement tools have like popped up, or however we wanted to describe it, which are actually very similar to the tools that we use in educational and behavioral interventions. So educational and behavioral interventions tend to look at individual change, right? And some of these metrics directly are derived from there. So I think some of the inspiration for some of the studies that the community has already heard about, I'm just going to do a shameless plug for our existing behavioral trials right now. We have a study that your foundation has been supporting so incredibly, and we thank you so much for it, the WING study, which is a behavioral intervention trial that is looking at the ways that we can in tandem improve behavior with communication. So the intervention itself that we're testing is called functional communication training or functional behavioral training. And in that model, sort of we're looking at areas that families, but also we talk about the Vineland changes, the changes in the Vineland that Audrey mentioned in Sid's paper, where there's certain areas like receptive communication that do show promise of small changes across time, maybe not at the rate that might show up in standard scores, but do show up in individual change scores, that there are opportunities to change communication and behavior in tandem, and that there are also behavioral interventions that are already doing that. So I think that in this work that has been done, we kind of separate all these things out, but actually I think what we're learning, or what I am hoping, is that we are able to sort of pull it actually all together, if that makes sense. And so I think on that side, I think there's a lot of promise there. I also think on the clinical sort of practice side, I think it takes us to really relying actually on some of the science to inform how we're going about measurement.
You should totally do a shameless plug for Wings. We will also include that in the show notes. And, again, it doesn't have to be exactly Wings that, what other families are already involved in. But this can inform kind of those practices as well.
That's actually a good point. The interventions themselves that are available in the community do sort of reflect and can support some of the areas that we're already seeing change. So we talked about Sid's paper and seeing some changes in some communication domains, and there are behavioral interventions in the community that not all practitioners are comfortable working with Phelan-McDermid or other syndromic conditions. They should be and could be, and that's what the WING study is about, is getting people comfortable using these practices with with more diverse populations. But the interventions that we have can be used to focus on these areas, and the measurement may need to be adapted from what we've learned in the studies, particularly around using the Vineland, rather than other measures that might not be as reflective of change.
Right. So we've obviously covered a lot of ground today, but also it feels like we've only scratched the surface, knowing how much rich data the Natural History Study has collected. But if you were to take a step back, giving your elevator speech about what these papers in this special issue really say and what you want the community to take away, what are your top three-ish takeaways?
Yeah, I'll just start by saying my first takeaway is the incredible importance, again, of families being involved and staying involved. That's just so critical to understanding a developmental disorder. So that's one. And then, I mean, two, we sort of just glossed over that this data came from, multiple different sites around the country. How hard it is to do that, but again, how important it is to do that, so that, we've got now different centers around the country that are trained in how to work with this population and hopefully be involved in treatment studies as they come. Those two things, I think, are things that we didn't really talk about too much. And then I guess the third thing is just what we're saying is that we are learning. And parents, the best part of the visits are the parents just telling us what's going on and using their words and describing the narrative. And we wish more than ever that we could sum that up in our studies, but it's impossible to. So we need to use these measures, because I know parents are like, why do you have to use these darn measures and ask these questions in the same way, and not ask, specifically for me. And so learning about the measures is just so important. And so we're appreciative for that.
Yeah.
I might add a 4.
Please
You
do.
said 3, but a 4, which would be along those lines. Like, what we've learned, I think, are that there's at least one measure that we can use across levels of intellectual functioning, ages, and even conditions, because in the natural history study with the other conditions, there's at least one, maybe a couple tools that we can. And because of all the work and the efforts that families put in, there are several that we're not going to use. And hopefully we won't do again with you, or you won't see if they're not applicable because of the developmental level, age, or condition that families come in with. So I do think that this was super informative for the field, for research, but clinically, hopefully some of the papers that we've already discussed around clinical practice guidelines, whether it's for the general medical community or psychologists in particular, will help save everybody a little bit of, a few more gray hairs across them.
Exactly. I also want to thank the community, the families and their loved ones who participated in these studies. Like you said, there is so much work that goes into it, but I think this podcast hopefully emphasizes how much it pays off to be in these studies, how much to stay in the studies as well is really important.
I do want to add is that the role of patients informing what's important and continuing to is so critical. And I want to make a plug for another paper that came out during this time that was the result of parents who who put together the externally led patient-focused drug development meeting during this time, and this paper is out in Orphanet called "Caregiver Perspectives on Patient-Focused Drug Development for Phelan-McDermid Syndrome," and I just want to read the conclusion, which is that caregivers prioritize and improve quality of life for their loved ones, characterized by improved cognitive function, improved communication, increased independence, and reduced risk of regression. And so the fact that those exact domains are the domains that we published on is not a coincidence. And so we want to keep making sure that we're focusing on those priorities, that it is coming from the families. So when we're talking about the Vineland is about increased independence. It's about independence with skills that are functioning of the child. So it's that. And then again, I'll say cognitive function, improved communication, and then reduced risk of regression. So that's what my eye is on, is what the parents are asking for. And so that's why I feel so determined to continue in this exact work.
I love that you highlighted it, and thank you for quoting it, because some of the things that came out of that is that you just mentioned that you love the narratives and the stories that the families are sharing. And so even though that might not be specifically within a database somewhere, that is in your mind, that is informing what the next generation of grants and studies look like. And it is always compared against the data. And so I think it's, you guys as part of this work are, doing really stakeholder informed research. And I think, like you said, that always has to be at the forefront. And I think you guys are definitely doing, the broader group and you two alone are doing a great job of making sure that what you're studying and what you're finding are patient and family informed. So I know we don't know about the third phase of the natural history study yet. And once we do, we will obviously keep our PMSF community informed and potentially have another podcast about what that looks like. But again, I just want to thank both Audrey and Latha for being here today and for their tireless commitment and dedication to the Phelan-McDermid syndrome community. We also cannot do this without your work and your dedication. So thank you.
Thank you for having us. And, we, again, are so grateful for all of us. So I think we're looking forward to hearing about the next phase as well. That Audrey had a strong hand in, making it easier for everybody.
I also, again, not only want to thank the community for their participation in these studies, but because of the broader dedication to the Phelan-McDermid syndrome and the donations to Phelan-McDermid Syndrome Foundation, we have continuously been able to fund travel to the different sites for the natural history study. And we've also been able to fund this interim period of repeat visits or these longitudinal visits because there is no funding right now between when the phase 2 ended and phase 3 began. So we're still able, or Latha and Audrey are still able to do their work and jobs in this because we're receiving donations that can go towards that. So thank you for that as well. All right, well, we will wrap up now, and I hope I see you both at the 2026 PMSF Family Conference in Colorado, where hopefully we can dig in a little bit more and maybe even get some like question and answer style stuff from families too to learn even more about what is in these papers.
That'd be great.
Sounds great.
All right, bye.